So, good afternoon, everyone. I hope I am audible. Can anyone just give me a thumbs up if I'm audible? Great. I have given a live show on FB as well, Facebook as well, because the intake of Zoom in this particular model is only 100. So many people are asking to participate in this webinar. So I have live streamed it on Facebook as well. So if anyone's friend is asking you, you can just tell them that it is streamed live on Facebook as well. First of all, thank you. Thank you all for taking some time. I know it's summer, it's very hot, and all of you must have come back from clinics. So thank you all for attending this webinar on full mouth rehabilitation. Thanks to Dental Masters Academy, Dr. Twinkle Jain for arranging things and organizing the webinar as well. This webinar is mainly aimed to probably talk about full mouth rehabilitation in a sequence. Now, if a patient comes to you and sits on a dental chair and you see certain signs and symptoms inside the oral cavity, like occlusal wear facets, abstractions, incised lip attritions, a lot of muscle pain, and you ask the patient that, we might have to go for restorations over the teeth inside the oral cavity, and patient says, yes, doc, let's go ahead and, do the restoration. You anesthetize the area and then you prep the teeth in one appointment or multiple appointments according to your convenience. And after preparations, you take a arbitrary jaw relation or a bite with either modeling wax or all wax, whatever, and you send the cast together like that with the jaw relation to the lab and expect a restoration out of it. And you loot the restoration inside the oral cavity and just check occlusion arbitrarily, visually and then probably by tactile, and ask the patient to leave. Now, I don't call this as full mouth rehabilitation. Everyone has gone through this phase. So there is nothing to shy away from the fact that everyone has gone through this phase of doing full mouth rehabilitations in this sequence. But full mouth rehabilitation is a journey. It's a serious journey. It's something that we need to understand about the somatognatic system in total. Only if we respect few things in the somatognatic system, then we probably come to the restoration finally and deliver that restoration inside the oral cavity. It is called full mouth rehabilitation. So I call full mouth rehabilitation as equilibration protocol, where you take all the steps in a sequence and give the restoration finally to the patient so that the patient is in equilibrium all the time. It becomes a self-maintaining system. So full mouth rehabilitation is all about elimination of interference in oral cavity. Now, if you see the public, if you see the population as such, 98% of the population will have interferences inside the oral cavity. So there is no person without interference inside the oral cavity. If I take my mandible to chew something in between maxilla and mandible, first the mandible goes and hits the interference, and then it goes into maximum intercuspation. That's what happens in most of us, in 98%. So when the mandible goes and hits the interference, that's what we call in layman terminology as a high point. That's where the problem starts. Because mandible is not going freely and sitting against the maxilla in a free range of motion, in a free arc. It's going and hitting a high point or multiple high points in the oral cavity, and then probably adjusting itself into maximum intercuspation. So in this fight between hitting the interference and then probably adjusting to the maximum intercuspation, there is a lot of destruction that is happening in the somatognatic system, not only in the oral cavity, around the oral cavity as such. And this leads to the occlusal wear pattern. This leads to abstraction. This leads to muscle pain. This leads to periodontal breakdown, mobility. This leads to anterior teeth flaring up with diastema. This is known as pathologic occlusion. Now, if I want to change this, I want to change something better, the first thing what I have to think is, how can I eliminate this interference inside the oral cavity? I need to catch. I need to find out where the interference is inside the oral cavity and probably do something to that interference. I might just grind it off. I don't know. The interference is big, so that I may not be in a position to grind it off. Rather, fill the other teeth to the level of interference so that when mandible goes and hits against maxilla, you don't have that slide anymore. The interference is now at the level of the other restorations that we have done. And that comes into restorative phase. Or if it is very huge, or if there are multiple anterior, posterior, huge amount of interferences, huge slides that are happening in the oral cavity, where we are not in a position to deal the case with either grinding or restoration, we might call our orthodontist and tell him or her that, please take care of the teeth and reposition them so that after ortho, we don't have interferences in the oral cavity. So my point here is, even orthodontists should think that ortho has to be done in centric, in simple words. If I am taking ortho as a total protocol and giving occlusion finally, the occlusion that we give inside the oral cavity should not have interference. So how many of us do grinding post-orthodontic treatment? Very less. We do ortho, and after ortho is done, minimal selective grinding is something which we need to take care. So all that has to be in mind whenever we are dealing with equilibration protocols. That's the first point I want to convey, that a full mouth rehabilitation is a serious journey. It's not something which we have to take it easy and expect the patient to adjust finally. No, we need to adjust ourselves to the oral cavity as a doctor and then probably deliver something to the oral cavity in a customized fashion. And that is known as full mouth rehabilitation. As you see this picture, this is what I mean to say maximum intercustation. Now this patient, if I take a picture like this from front, you will see that the mandible is going and nicely sitting against the maxilla. I don't see anything gross here if I see the picture. Just hold on 1 second. Hello.
Audio is very low. Is it okay now? Is it clear than before? Okay, okay. Sorry for that. I think my microphone was not working well. So I'll get back to you again. So what I was telling you when I was talking about the first slide is about the interference. Now, most of us, when you see the chunk of population, most of us have interferences inside the oral cavity. So when the mandible is hitting against the maxilla, when probably a patient or a person is chewing upon something, the mandible first goes and hits the interference and then slides into maximum intercuspation. So if I want to probably eliminate this interference, I need to think in multiple protocols. If the interference is very small, probably I have to think that, I might grind off this interference and then make sure that the mandible is sitting against maxilla well without any kind of slide. That slide is harmful. That is what is creating destruction in the stomatognathic system. And let's say if the interference is huge, there are multiple interferences inside the oral cavity. then I might think of restoring the other teeth to the level of interference so that when the mandible is closing down against maxilla, everything is at one level. Now I don't have that hit, I don't have the slide that is happening inside the oral cavity. If the interference is very huge and if there are anterior, posterior, multiple number of interferences, then probably I would call my orthodontist and ask him or her to do repositioning of teeth so that after repositioning, we don't have interferences. So even orthodontists, when we are doing orthodontic treatment, should make sure that once occlusion is established, once occlusion is achieved inside the oral cavity, there should not be interferences after that inside the oral cavity. Then only relapse is very, very less post-ortho. How many of us do a minor selective grinding post-ortho? We don't do it. Visually, we see that we have achieved class 1. Visually, we see that, we have premolar to premolar, molar to molar relationship established. Visually, we see that we have overjet and overbite. The patient is looking good. Phonetics are fine. But occlusion is something which we don't take care. Only if that is taken care post-orthodontics, then majority of the relapses are taken care of. So if you see this picture, you will understand clearly that in maximum intercuspation, we don't see any kind of changes. We don't see any kind of things. But only when I guide the jaw into centric, in the second picture, as you see here, you see something gross. In this first picture, you see that, the upper and the lower teeth are intercuspating well against each other. But if you see the second picture, you see that they are not intercuspating well. You have spaces that have crept here in between maxilla and mandible. So when the patient starts chewing on something, this is the position, this is the postural position the jaw takes first. And once it hits all the interferences, then it goes into the first picture, which is your maximum intercuspation. And in between this travel, in between this slide that is happening inside the oral cavity, the stomatognathic system is taking the load. The muscles are taking the load, the TMJ is taking the load, the teeth are taking the load, and the periodontium inside is taking the load. There happens destruction. Now, let's say I convert this second picture into first picture by means of either selective grinding or by means of restorations in the spaces that I have here, or by repositioning the teeth into the spaces that I have here. Then what will happen? I have achieved equilibration. And that's what we need to remember. I request all of you to probably use the chat box only if it is urgent or emergency, because I have to again open up the chat box and see. Let's take up the questions at the end of the session so that I need not shuffle myself here and there in between the chat box and the presentation. So ICP is equal to intercuspal position and RCP is equal to retruded contact position. The position of teeth in maximum intercuspation is what is known as ICP. That is what you are seeing in the first picture. The second picture is in centric. Now in centric, the position that you see is known as retruded contact position. Why is it called retruded? Because it's slightly posterior to ICP. ICP is always anterior to RCP. So you have to understand that maximum intercuspation is always anterior to centric relation. So the jaw goes back first, hits the interferences in CR, and then comes into the maximum intercuspation. If I don't have interference, what will happen now? The jaw goes directly into MIP or ICP, maximum intercuspation, without RCP, without interference. So the main goal of FMR is to eliminate this RCP or the retruded contact position as the first interference that happens inside the oral cavity. So as I just discussed, these are the protocols that we follow to eliminate the interference. We either do selective grinding or reshaping with a burr. We either do full mouth restorations with any kind of restorations. We either do orthodontics or repositioning. Finally, we opt for surgery. That is different section altogether. Let's not touch that. That comes into orthognathic surgeries and, different kinds of resections. Here today, we are talking about the second section, which is your full mouth restorations. So full mouth rehabilitation in the form of restorations is what we are going to discuss now. We are not going to talk about selective grinding here. We are not going to talk about orthodontics here. But remember, all these four fall into stomatognathic equilibration. So every case need not end up with restorations. Please understand. Every case is different. We might take up one case for selective grinding and finish it off and tell the patient that you are not into this category, boss. You're not into the category of restorations. Let's finish your case with grinding. That will take care of your problem. If the patient comes to you with signs and symptoms where there is wear of teeth, then probably you have to select restorations. A patient comes to you with malalignments and some problems, then you have to consider orthodontics. Sometimes we consider all three together or two in between as a combination as well. After ortho, I might probably do a selective grinding, which is minimal. After ortho, probably I might restore the teeth in a conservative manner and do selective grinding. So it's a combination. It's a multidisciplinary approach that we need to understand when it comes to FM. First takeaway. So I'll be telling you 30 takeaways in this webinar. The first takeaway is whenever you do FMR, please make sure that the TMJ is healthy. Without TMJ being healthy, if you do FMR, it's a failure. You are actually doing a lot of destruction to the stomatognathic system. So I would probably ask all of you to do this load test. What is load test in simple words? Guiding the mandible into anterosuperior position. You can clearly see this Rocabado map where the load test is demonstrated. You can clearly see that the doctor is holding the anterior part of the jaw with one hand, pushing it back and lifting at the angle with the other hand. This motion is a hinge, which is taking the condyle into anterosuperior position in the glenoid fossa. The anterosuperior position in the glenoid fossa is known as centric relation, in simple words, where you don't have pain. The patient will not experience pain if the joint is healthy. And if I'm guiding this jaw in anterosuperior position, like what I've shown in the picture here, and if the patient jumps with pain, it means that the joint is not healthy. As simple as that. There is no disc in between the condyle and the glenoid fossa. Instead, there is something else which is creating pain in the joint. And that something else is your retrodiscal tissue, usually. So if the disc is displaced and the retrodiscal tissue is pulled anteriorly, then the patient will experience pain. And if the patient is experiencing pain when you do load test, that patient is not fit for FMR immediately. You have to treat the joint first, take it as one entity, make it healthier, and then probably proceed to FMR later. It's again a staged procedure. It takes few months. So first takeaway is please do load test. And if load test is positive, stop FMR. If load test is negative, you can proceed with FMR. Takeaway 2. Always FMR has to be done in centric relation. You cannot consider maximum intercuspation until unless the patient is already equilibrated. If the patient is already undergone orthodontics and the minor selective grinding has been done and there are no interferences inside the oral cavity, yes, good to go. Maximum intercuspation is the relation that we take. But there is a lot of occlusal wear inside. The patient is having a lot of pain when it comes to the head, neck, back. Then yes, you might have to consider taking the jaw into centric relation, because if you do restorations in maximum intercuspation now, whatever problem was there before is continuing now on the restoration and the restorations break down. So kindly do FMR in centric relation. That's the takeaway number 2. Takeaway number 3, diagnostic mounting has to be a serious protocol. in FMR. You can't consider mounting just like that. You can't just take maxilla, mandible, put with your hands in any relationship that you want and mount it on a hinge articulator or a mean value articulator. No, there is a serious protocol for it, and we have to follow in order to do an FMR. So takeaway number 3, we need to do diagnostic mounting. How that has to be done, we'll see in the next slides. Kindly use semi-adjustable articulators only when you do FMRs. Do not use mean value articulators, do not use hinge articulators, because if I use a mean value articulator, max to max, I would be having only static occlusion in a mean value articulator. Just opening and closure, that's all. But if I take a semi-adjustable articulator, or if I take a fully adjustable articulator, then I have dynamic occlusion that I can check for or probably create in a restoration. So FMRs have to be done on semi-adjustable articulators only. You cannot consider doing FMRs on mean values and hinge articulators, which I keep seeing a lot. And the moment I try to explain, they say that there is no change, finally. But yes, if you are doing FMR in a sequence, then yes, please invest on a semi-adjustable articulator. There are many companies in the market. I would not say one company. There are many companies, starting from Hanau to Whipmix, to BioArt, to Corrident, to Artex. Many companies are there. So you can invest on one simple semi-adjustable articulator and you can proceed. Off late, what we are doing is we are depending on virtual articulators. The second picture, right hand side, if you see here, the second picture is your virtual. This is known as digital articulator. So we are doing a lot of digital FMRs as well these days. Now that the scanners are like mushrooms in the market now, and every dental clinic is now investing on a scanner, probably after 1 year from now, I see the shift from conventional to digital FMRs. We've started already. We started doing FMRs only digitally now, more than physically. But for someone who doesn't have a scanner, who is not probably into those digital protocols, at least a physical semi-adjustable articulator that is seen in the slide on the left side. So takeaway number 4, use a semi-adjustable articulator only for diagnostic mounting in FMRs. Takeaway number 5, maxillary cast mounting has to be done with a face bow or a dentofacial analyzer. It's called DFA. One of these two can be used to mount the maxillary cast on a semi-adjustable articulator. You cannot use your hand to mount maxillary cast on a semi-adjustable articulator. You can't use a thread just to see how is the plane and then mount the maxilla. You have to use a face bow, then record the hinge axis and then transfer it onto a semi-adjustable articulator. It's a nice protocol. It's a very easy protocol. If you learn, hardly 45 seconds to 1 minute, max to max around 1.5 minutes if you start doing face bows. The left one, what you're seeing is the physical face bow or the conventional one. The right one, which you're seeing, is the digital face bow. We're not using digital face bows much in our country still, but probably after 1-2 years, we will be there. So takeaway number 5, face bow. Takeaway number 6, centric record has to be taken to mount the mandibular cast. As I already explained you, that you have to mount this in centric. You can't mount this in maximum intercuspation. You need to take a centric record. You need to have a solid, stable record, which is reproducible, which is repeatable, and which is recordable. All 3. So you need to have this centric record and mount the mandible against the maxilla in a semi-adjustable articulator. So takeaway number 6, a stable centric record. I would not suggest light body to the centric records because they are not stable. And you cannot mount the mandibular cast without any flexure there. It starts bending, it starts dancing inside the semi-adjustable articulator. So don't use these light bodies. If you want to use a bite registration paste which is hard, or probably an oluvax like this, which I've shown in the picture, which is cross-arch stabilized on both the sides. This is the best for mounting when it comes to maxilla versus mandible, or a bite registration paste, which is hard. Takeaway number 7, you need to do deprogramming to achieve centric relation. What is deprogramming in simple words? You are actually relaxing the lateral pterygoid. The only muscle that is nearer to the condyle, which is attached to the condyle and which dictates the movement of condylar movements in the glenoid fossa is your lateral pterygoid. So if the lateral pterygoid is tensed, if it's very stout, let's say, then I cannot easily get this anterior-superior position in the glenoid fossa. I cannot guide the mandible into CR easily. For that, I need to relax the lateral pterygoid. So to relax the lateral pterygoid, I need to do deprogramming inside the oral cavity. Deprogramming is nothing but taking away the posterior teeth against each other. As long as the posterior teeth are not touching against each other, you have a space in the posterior. And as long as you maintain a space in the posterior without any contact, the lateral pterygoid is relaxed. Brain sends signals to the lateral pterygoid that, you can relax. There is no contact, you don't have any work, you rest. So it's a holiday for it. And the moment it becomes relaxed, the jaw becomes buttery. The jaw is easy to manipulate. And we can easily get the centric relation in the glenoid fossa. So you can either introduce a very small jig, or you can either use different types of deprogrammers, which I'll be showing in the next slide. So deprogramming has to be done inside the oral cavity to achieve the centric record. There are many kinds of deprogrammers. You have stock, you have custom made, but I would prefer custom made anytime because I am customizing it according to the patient's oral cavity. Stock has to be relined always. Suppose you take a Lucia jig, it has to be relined with a bite registration paste, and you have to introduce that onto the maxillary centrals. It has to be stable enough inside the oral cavity so that you don't have platform differences again when the patient is moving the mandible here and there. All these are some problems with the stock. But when it comes to the custom made, as you see in the second picture on the right side, this is known as Coase deprogramming. The Coase deprogrammer is a palatal platform which is posterior to the palatal surface of the maxillary centrals. It falls here. So if your mandibular anteriors fall on this platform, number one, it's quite stable, it's quite retentive. Number two, it is socially acceptable because it is not seen like a Lucia jig outside. Number three, it is easy for the teeth to get discluded. I need not actually open the mandible too much to get it onto the incisal edge if I'm using a Lucia jig. Here, I can just rest it on the palatal surface with minimal disclusion and achieve the results of deprogramming. So I would always go with a Coase deprogrammer as a custom-made deprogram. If you want something better than Lucia jig, you can go with the pattern resin deprogrammer, which you can make with pattern resin. Pattern resin is more dimensionally stable, more dimensionally accurate when it comes to the fit as well. So you can use the pattern resin. Leaf cage is also many times used clinically chairside. If I want to get that first point of contact in the centric relation, I can start decreasing the leaves and find the first point of contact in the oral cavity by asking the patient to just lift the hand whenever the patient feels that first point inside the oral cavity. Literature suggests that leaf cage might distalize the condyle in the glenoid fossa, but practically I have used a lot of times leaf cages. You have to be a little careful, that's it. You need to make sure that the jaw is not going back rapidly or swiftly. You have to do something known as half bite with the leaf cage. Then you will end up getting that first point of contact inside the oral cavity. So these are the different types of deprogrammers I usually use when I do FMRs. I use this for chairside. What do I mean by chairside? When the patient is asymptomatic, in simple words. When the patient comes to you with no pain, no discomfort, and if you feel that the jaw is moving very nicely, freely, the jaw is not held in position by the patient, is not very rigid, then yes, I can go with a chairside deprogrammer. I usually use a lucid jig or a pattern resin, one of these two for chairside. To get the first point of contact, as I explained already, a leaf gauge. For long-term deprogramming, I would prefer a coarse deprogram. Probably patient comes to you a lot of muscle pain, headaches, the neck pains, back pains. Then yes, you can prefer a coarse deprogrammer for around 10 to 12 days. It's not a hard and fast rule that you have to give around 10 to 12 days. You can take a call according to the symptoms that decrease. Don't keep it for long because the posteriors are discluded and you might have supraeruptions that set in into the space. So take a call quickly. As long as the patient is recovering from the pain, from the discomfort, you can take a centric record and proceed. So a long-term deprogramming is done only when the patient is symptomatic. A chairside deprogramming is done when the patient is asymptomatic. Let's say the patient has come back to you with a lot of pain instead of giving deprogram. As I said, symptomatic patients have to be given deprograms. If patient comes back and says, doc, I'm having a lot of pain, even after the deprogrammer, and I'm not getting a relief, then you have to check the load test again. You have to see whether you have not diagnosed the case properly. It could be load test positive where it is an intracapsular disorder. There is a disc disorder that is there inside the joint, and you have started with the deprogramming. And the moment you open up the posterior teeth, it's loaded again. And once it is loaded, the pain doubles up. And the patient comes back running to you saying that, the pain is not going down, rather it has increased. So you need to check first load test. Now load test is negative, let's say. Then yes, you need to check the design of the deprogrammer. Is my platform straight? Is it parallel to the occlusal plane? Is it perpendicular to the lower anteriors? Have I increased space in the posteriors much? More than 2 millimeters that is required? Have I loaded the joint again? So all these things as a design on the deprogrammer has to be evaluated once the patient comes back to you with pain. Never take centric records without deprogrammers inside the oral cavity because the patient doesn't know where to stop. Simple. The patient might go and again go into maximum intercuspation. We have struggled so much to get that CR, centric relation. And after deprogrammer is removed, the moment patient goes and bites down, the patient is no more in CR. The patient goes into maximum intercuspation. So always take the centric records with the anterior deprogrammers in place. The left one is the physical centric record. The right one is the scan that we do in centric space. So these days, we are doing a lot of scans as well for the centric spaces. Before, we used to do a lot of physical records, and now we are going with scans. I would suggest to take a protrusive record when you take a centric record. The moment you finish taking a centric record, immediately take a protrusive record and keep it, store it in water. You can either use Oluvax, you can either use modeling wax because the protrusive record is not used by the lab. The centric record always has to be with Oluvax. You cannot take modeling wax and keep centric record stable. No, because you have to send it to the lab for mounting. But when it comes to the protrusive records, you can go ahead with modeling wax because this is used to set the horizontal condylar guidance on articulator. So that you, as a doctor, you yourself can do this. So you need not actually send this to the lab and expect them to do the HCG. If you see here, the mounting is in a sequence. So there is a mounting mechanism for maxilla. There is a mounting mechanism for mandible. And if you take the digital scan, there is again a mounting mechanism. So either physically or digitally, you need to follow a kind of protocol, certain steps to mount the maxilla against mandible. So kindly do not do with hand. hand mounting without any kind of jigs, without any kind of supports is not good in FMR. We need to follow a sequence. Then only everything falls in a sequence, and finally the restorations would not have interferences inside the oral cavity. This is what I was speaking about. The protrusive record is used to set the HCG. In simple words, for people who don't know what is HCG, horizontal condylar guidance is the movement of condyle in the glenoid fossa when the patient is protruding the mandible or opening up the mandible, in simple words. So when the condyle is moving the glenoid fossa and the patient takes forward and we record that forward movement, it is known as protrusive record. So with the protrusive record, what am I going to record in the glenoid fossa? I am going to record the travel of the condyle in the glenoid fossa, which is known as horizontal condylar guidance. Now, if I put this record on articulator and adjust the HCG setting on the articulator, my record is helping me to achieve what is there in the glenoid fossa of the patient on the articulator. Usually, according to the average standards, it's around 30 degrees. So many people, what they do, instead of taking protrusive records, they set at 30 degrees and start with the procedure. I would like to customize the protrusive records and HCGs because every patient's glenoid fossa is different. Sometimes I might get 45, sometimes I may get 50. According to this, my restorations are designed. The posterior disclusions, the shallow occlusal anatomy, all that I want as standard protocols in the occlusal when it comes to the final restoration is achieved with this HCG. So I'll come to know whether the HCG in the patient is steep or shallow. Accordingly, I'll work on my restorations to get the disclusions inside the oral cavity. So the left one is the physical HCG record on articulator. The right one is the digital setting. If you see here, there is condylar angle. That needs to be set. And then we need to proceed. There is one more thing, what is known as Bennett angle when it comes to FMR. Usually Bennett is set at 15 degrees. We don't take any lateral records for Bennett. We keep it at 15 degrees and then we proceed with the restorations. So you need not worry much about the Bennett angle. Just keep it at 15 because Sir Dawson says that the immediate shift that happens with the mandible is almost zero. So we keep the Bennett angle at 15 degrees and proceed with the restorations. Only HCG has to be customized. That customization is done with protrusive record. Vertical dimension is I would say it's a combination procedure. I would take the face into consideration. I would take the articulator into consideration. Now, how is my face looking? How is the articulator mounted? I take the combination of these two and set the vertical dimension inside the articulator. The best thing what I do is, the moment I get the centric record, this is the centric space, what you see here. I remove the centric record and drop the maxilla onto mandible. Now, when I drop the maxilla onto mandible, it is dropping down in centric relation. It is not dropping down in maximum intercuspation now because we have recorded centric here. And when it drops down in centric relation, the first point, maxilla goes and touches the mandible on articulator, is your RCP, as I showed in the first slide, which is your retruded contact position. And that is the interference that is existing inside the oral cavity. Now, according to the RCP that is there on the articulator, I decide whether I have to do selective grinding, I have to fill up these spaces, or I reposition the teeth. So this diagnostic mounting also helps me to categorize the patient into a treatment planning. Whether I have to push this patient into selective grinding, whether I have to push this patient into probably full mouth rehab in the form of restorations or orthodontics. So that's how I actually take a call after diagnostic mounting in many cases that I have to send this patient for ortho. I have to send this patient or grab this patient for a restoration, full mouth rehabilitation. So you take a call of VD according to this RCP, the first point of contact. At the first point of contact, if you have good space for your future restoration, don't increase VD. In simple words, done and dusted. You need not increase the VD if the first point of contact gives you space for your future restorations, especially in the anteriors. Now, let's say there is a collapsed bite. There is absolutely no tooth structure that is left out, not ferrule for the restorations in the future. Then you might have to increase the VD till you achieve space for the restorations. Now, on articulator, you have an incisal pin. You have to keep increasing millimeter by millimeter till you get that space for the restorations, and then you can send it to the lab. Along with the assessment of phonetics and aesthetics. That is important. That's where DSD comes into role. The digital smile design. You can actually do the smile designing according to the patient's teeth and then give. There are other methods also. You have Shimbashi's technique, Shimbashi's number, which is a standard reference zone, where you get a standard value between the upper gingival margin to the lower gingival margin. You can give that value to the lab and ask that lab to design your restorations according to that. But I would prefer this method. The many methods, I would prefer this method. Finally, checking the Niswanger's VDR and VDO. The vertical dimension at rest and vertical dimension at occlusion. In between the freeway space. So all these things need to be checked whenever you probably do a vertical dimension assessment. Clinically, we see for the aesthetics, phonetics, on the articulator, we check whether we have space for the restoration or not. We combine both and we take an assessment. Do we have to increase VD? Do we have to decrease VD? Do we have to maintain VD? My best bet is on maintaining VD. Most of the cases do not have an increase more than 1 millimeter of vertical dimension posteriorly, because every 1 millimeter posteriorly gives you 3 millimeters anterior space. It's an arc of opening. So we don't require much in many of the cases unless it's collapsed completely. It's dead inside the oral cavity. Then yes, you might have to increase a little. So VD is an overhyped concept. From our undergrad days to the postgrad days to the probably practice after, pass out of the colleges also, this is an overhyped concept. It has to be simplified. I bet on maintaining VD rather than unnecessarily stretching the masseter so that it comes back and destroys everything in between. That's an important point. Now, once you send these articulators, the lab will do the wax up. It could be either physical wax up with wax or printed resin. It could be milled or conventionally done with hand. It could be a digital mock-up, which is done on a digital articulator. Now, this is printed in the form of printed cast, and they send this to you. So now either on this or this, you make an index. So what am I doing here? I'm capturing the new position of teeth in centric relation in that vertical dimension that I've set. Now, this is the starting point of FM1. If you have done the index well, a rigid index, it should not flex, it should not bend. So I use a lab putty here. Rather than using a normal clinical putty, I use a lab putty. Zermatt has, Pultine has, you can go into the Google and invest on it. Take a nice lab putty, do a nice indexing. And then this is your digital index. This is a physical index, this is a digital index. This is a rigid index. Silicon index, which is still better. Printed index is still better. We are using printed indices now, these days, where it is very rigid and the transfer is bang on inside the oral cavity. So after the index is prepared, then we put something known as bisacral in the index, which is your pro-temp, and do the transfer. Now, when you do the transfer, it will be rough. It will be slightly gross, but you have to again modify, finish, polish so that, the patient walks back with an assessment of what the doctor is going to do finally with my restorations. So this pro-temp transfer is a test drive for the patient so that the patient feels better. Never give these sharp margins. This is just the transfer and then immediate picture. You have to again do modifications, do the corrections, finishing, polishing everything, and then send the patient if the patient wants to walk away with the ProTemps. What I do is I don't let the patient walk away for too long with ProTemps because I don't believe in ProTemp dealing with the soft tissue. I want the soft tissue to be healthy. So what I do is I stage the patient for my tooth preps within 48 hours. I ask the patient to come back and we start with the tooth preps. Now at this stage, where I've done the ProTemp transfer, I've finished and polished the ProTemps, there could be some changes. The visibility might not be the same as I expected. Number one, the lab has changed it. So I might have to add a little of composite here for increasing, or I might have to take a burr and reduce to decrease the visibility. Phonetics again, the F and V sounds, the TDS sounds, all those sounds I check and make necessary corrections. Any soft tissue corrections here, again, I do it. Occlusal corrections, yes, I check for occlusion again. There should not be interferences here. If there are interferences, you have to check it and correct it. So many times we have to correct this ProTemp again inside the oral cavity. If your transfer is very nice, and if the wax patterns, if your centric was very nice, and if the wax patterns are transferred into the oral cavity just like that in centric, you're lucky. Many times you might have to do some changes. So once you're done with these changes, especially on the palatals of the upper anteriors, you might have to do this customized incisal guide table. So you have to just put some resin on the incisal table and do the movements of the incisal pin so that the anterior or the protrusive guidance is recorded on this table of the modified ProTemp, which you have done inside the oral cavity. And this will be used by the lab when the lab is actually doing the final wax patterns, final design, and final restorations to just replicate the protrusive guidance that we have achieved. The lab uses a customized incisal guide tape. So this is an accessory step for you only if it is needed, only if you feel that you have developed anterior guidance where it was absent, then yes, you can proceed and take a incisal guide table which is customized. Otherwise, you can use the normal stock guide tables which you have with the articulators. Always do temporary guided teeth preparations. Now, why did I do the transfer inside the oral cavity? Number one, to see how the final restorations look like. Number two, so that these temporaries will guide me for tooth preparations. If there is already 2 millimeters of temporaries above the tooth, which is not prepared, it means that I have enough space for my restoration. The 2 millimeters is taken up by the ProTemp. So I need not again go on to the tooth and reduce 2 more millimeters on the tooth. This 2 millimeters is enough for me, which is of ProTemp space. So I can go conservatively with my tooth preparation because I know now that, I have good space. Without ProTemp, I would not know that. I directly go onto the tooth, take a burr, start reducing it till I get 2 millimeters of clearance. Now that would be 4 millimeters of clearance now without ProTemp. Now that ProTemp is there, the moment I touch the tooth, I know that I have gone through ProTemp by 2 millimeters and I have good amount of space for my future restoration. So it guides me. That's why it's known as temporary guided tooth preparation. These are overlay preps. The tabletop preps, we finish this case very conservatively. But yeah, sometimes you might have to go with the full coverage restorations also. That time also, the ProTemp will guide you. Labially, it guides you. Occlusally, lingually. How much space I have for the restoration. Can I increase it? Can I decrease it? Can I maintain it? All these are guided by the ProTemp. That's why it's called temporary guided tooth preparations. Please do not send the patient without temporizations post your tooth preparations. The moment you finish tooth preparations, the patient has to walk away for at least 15 to 30 days with the temps. These are not the acrylic temps. These are PMMA temps. I ask my lab to send me milled PMMA temps. I loot the milled PMMA temps so that the soft tissue integrity to the restorations is very nice. It should be well polished. Then only I would probably get a soft tissue that I desire. There is no soft tissue trauma. If I use a ProTemp, which is sharp, as a temporary, your soft tissue would not be healthy. So I usually use the PMMA milled temporaries before the patient walks out. I ask the patient to come after 15 days to 30 days according to the case, and then check whether the patient is doing good with visibility, phonetics, occlusion. There should not be any chip off of the restoration, especially on the inclines. There should not be a space that have crept in the anterior area by taking the jaw backwards. Many patients come back to you after 15 days and you see an anterior space that is crept, because the jaw has gone back a little more. You have not done sufficient deprogramming. You have not taken the centric record correctly. So the jaw went back after 15 days. And once the patient comes back to you after 15 days, you see that the centric is not correct. And you have to again probably repeat the centric record. So these are few things which you have to look out for. The many things are there. But yeah, these are the few common things that we look out for when the patient comes back. Is the patient speaking well? Patient eating well? No pain of muscle? How is the joint doing? So all these things you have to see in a sequence, and then now start with your restorations. Now that the soft tissue would have become friendly with these restorations, temporaries, we take out the restorations and then we do the final or the definitive restorations. I would prefer the tooth preparation posteriors first and anteriors next, because I am going to preserve the protrusive guidance. I am going to use the VD and centric the same. But when it comes to the posteriors, the definitive restoration, I would probably prefer anteriors doing first and posteriors next, because I want to again recreate the protrusive guidance which I have recorded already, or the anterior guidance. So the sequence usually we follow when the patient is accommodating and when it's a straightforward case is posterior anterior tooth preps and anterior posterior definitive restorations. I will get back with the points 19 and 20 again. Just let me finish the presentation. I'll get back to you again. Many times, even on the long-term temporaries, I might have to do few corrections. As I just explained, there could be some swelling here. See, this is a patient who came back with few problems after long-term temporaries with milled PMMAs. So you need to assess in multi-fold directions. You have to see the soft tissue, how is it? You have to see how is the occlusion, static occlusion. You have to see the dynamic occlusion. In protrusion, do we still have this posterior disclusion? In late protrusion, do we still have canine guidance maintained, or has it come down? Is there any chip off on these restorations? All this we have to see and do modifications accordingly even on long-term temporaries. Stabilize the patient till you don't see any kinds of problems inside the oral cavity. That's my suggestion for you if you're doing FMR, because if you don't stabilize occlusion inside the oral cavity with your temporaries, you are not going to get it on the definitive restorations. On the definitives, you'll have problem again. And to change the definitives, it's a big task. You must have luted them or bonded them. We don't know. So whatever you want to do it on the temporaries. Get the stabilization done. Patient has to be happy in all the directions. Then only proceed with your definitive restorations. This probably a 10-year follow-up now, if I'm not wrong. So the temporaries have to be changed to definitive restorations in a sequence. Don't remove all the temporaries and change it to a definitive restoration. We have that protocol as well, which is known as cross mounting. That's a different scenario altogether. But if you want a sequence, if you want the centric to be maintained, if you want the VD to be maintained as you have decided before, if you want the aesthetics and phonetics to be maintained as you have decided before, you have to follow a sequence which is your anterior-posterior sequence. First, remove the temporaries in the anteriors, change them into definitives, let the posterior stops be there on the temporaries. And once you're done with the anterior definitives, go with the posterior definitives sequentially. Make sure that you have stop everywhere when you're doing definitives. Let it not be an open oral cavity where you don't have a stop, you don't have a guide, you're lost in a sea. Don't go to that position. Do your restoration sequentially. Then only you will have peace of mind. The sequence which I've just discussed is known as Pscholer's philosophy. The posterior anterior for tooth preps and anterior posterior for definitive restorations. We have something known as twin table philosophy, where we do the posterior definitives first and anterior definitives next, especially in deep bites, where I might have to concentrate more on the anterior guidance with posterior disclusion. I take the twin table philosophy. That is not required at this stage of the webinar, because clinically, the first Pscholer philosophy is more than enough. The twin table philosophy is slightly advanced when it comes to the FMR protocols. So all of you, whatever I've told till now, if you can just keep it in mind, that we have to follow the posterior anterior and antero posterior sequence, then that holds good as of now for the clinical practice. Cross mounting is doing everything together. Once the temporization stage is done, we remove all the temporaries. We take the records inside the oral cavity at one go, maxilla versus mandible. And then we submit this maxillary tooth prep cast, mandibular tooth prep cast with one record to the lab, so that you get the bistrine of all the restorations together. It's not in a sequence, basically. You're cross-mounting it completely together. That is also not required at this stage. So kindly stick on to Pscholer philosophy, which gives you predictable results marvelously well. This is again a 6-year follow-up for the tabletops, which I had done before. Now we are thinking to change these anteriors as well very soon. That time she was not ready for the anteriors because she liked these anteriors at that point of time. She had good visibility. Her phonetics were not disturbed. So I also didn't force her much, as I had good anterior guidance with posterior disclusion and canine guidance. Now, what is occlusion? Occlusion is mutually protected in natural dentition or restorations. Whereas in dentures, it is bilaterally balanced occlusion. In simple words, we don't give balance in the natural teeth. We don't give balance in the fixed. We need mutual protection because you have periodontal ligaments, you have bone, you have teeth. Whereas in dentures, we don't have all these things. You can balance them, create contacts everywhere so that the stability of dentures is increased. Here, stability is already there. So what we have to do, we have to protect that. That's why we give mutually protected occlusal scheme. As the patient bites on, static contact should be there on the posteriors. Static contact should be there on the anteriors as well. But the load is taken more on the posteriors and the load is taken less on the anteriors when the patient is doing opening and closing movements. When the patient is coming forward, which is known as protrusive guidance, you should see posterior disclusion. When the patient is doing late protrusive movements, side movements, on the working side, you should have canine that guides and all other teeth discluded. On the balancing side, you should have all teeth discluded out. Similarly, on the other side. And this is known as canine guided occlusion. If canine is weak, let's say, if canine is absent, let's say, then you have to take the help of premolars. Sometimes the mesiobuccal cusp of first molar as well. That is known as group function. So depending on the canine status, you can take a call, whether I have to give a group or whether I have to take a canine guided occlusion. But in implants, if you're doing FMR in implants, it's always a group. Because in implants, the canine periodontal ligament, canine root, nothing is there. It's all implants. So I need to protect implants by spreading forces. That's why we go for group in implants, a shallow group function. So when it comes to natural teeth, kindly remember mutually protected occlusal scheme with canine guidance is the standard protocol. A group function is not standard. You give it only when the canine is weak or the canine is absent. Kindly do all the corrections in bistrine. Now, whatever I've told you till here, you have to do all these corrections in bistrine. Ask a bistrine from the lab and then do the corrections. See the functional cusp to the opposite fossa contacts are maintained here. Now if you have premolar here, one functional cusp, two here, opposite fossa, marginal ridge contacts on the premolars, of central fossa contacts on the molars. Not necessarily that you have to get all the four, I would say. If you're getting two or three this side, two or three this side, that's quite enough for the stability of the system. You need to create a tripod or a quadrupod here. For that, we need two static contacts here on the anteriors that drive the restoration forwards. If you have multiple static contacts, don't worry, it is good. Anterior groove function is always beneficial, whereas posterior groove function is harmful. If you understand this statement, majority of the occlusion is understood. You need to have a drive in the anteriors, not on the posteriors. You need to have only stops in the posteriors. So dots at the back and lines in the front is static stops on the posteriors and drive protrusive guidance on the anteriors with posterior disclusion. Canine guidance with posterior disclusion. All these corrections you do in BISC train. Check with a articulating paper. Which articulating paper I'll show you in the next slide. Take that articulating paper. Check in the posterior. Are you getting these equal intensity stops in the posterior? Bilateral, harmonious. Am I getting stop in the anterior as well? If I have open bite, should I do some corrections here? Should I ask my lab to build up on the palatal? So all these things you do, the corrections in BISC train. Never do it after glazing, after polishing. Kindly invest on these. These are very important. A Miller forceps should be there to hold the articulating papers. Don't use tweezers anymore. Invest on a good articulating paper, good company. I usually use Bosch. So a 40 micron is more than enough for the posterior, whereas a 12 micron or 8 micron is enough for the anterior. Finally, a 12 micron can also be used to see the stop. Once I've done all the corrections, I keep the 12 micron, which is known as shim stock, a metal foil in between the teeth to hold, to just see how the teeth are holding against each other. Am I getting resistance or not? Usually the articulating papers are 200, 100, 40, 12, 8. This is the sequence you might have to invest in your clinic. 200 is for the first point of contact and chewing patterns inside the oral cavity. 100 is for the complete dentures or polished surfaces, glazed surfaces on the ceramic. 40 is for BISC trines on the natural teeth corrections, tabletops, whatever. 12 and 8 are for implants and for the anterior zones of natural teeth. And finally, for the final holds. So this is how you need to stage it up. Take the articulating paper help and start decreasing the intensity from 200 to around 12 microns or 8 microns, according to the case selection. Kindly make sure that this is a temporary stage, what I've shown the picture. Once the temporaries are removed, you have to bond the partial restorations always. Never loot them. So partial bonded restorations we call because they're bonded. Full coverage can be luted, can be bonded. We take a call according to the ferrule that is present, the tooth structure that is present. So either lute, either bond. Partials should always be bonded. Full coverage, you can take a call according to the tooth structure that is present. Material selection is very important. If you're bonding something in the posterior, it has to be lithium disilicate. Don't use a zirconia, though it can be bonded. There is a protocol for it also, but the zirconia bonding is far inferior when you compare the lithium disilicate bonding. So a posterior partial bonded restoration is good to go with a lithium disilicate. Whereas a full coverage, you either give a monolith or a layered restoration, depends on the space that is present for the restoration, number one. Number two, the parafunction. If the patient is a bruxer, known parafunction, then yes, try to avoid a layered restoration, give a monolith as much as possible. Metal is still a gold standard in the posterior. A lithium disilicate single bonded restorations you can afford to give. I would not prefer a zirconia and a parafunction or a bruxer because the load is more on TNJ with zirconia. There is a myth that zirconia might abrade the opposite tooth. It will not, as long as it is polished. You have to make sure that it is polished well or glazed. After that, it doesn't. If you take a burr and scratch it up, yes, it becomes a lethal weapon inside the oral cavity. So you have to take a call accordingly. Material selection is very, very important in FMR. You can take a combination many times. So whichever philosophy you follow, FMR is all about restorations in centric, number one. No interferences post restorations, number two. Do you have mutually protected occlusion inside, number three. And finally, vertical dimension has to be respected, number four. If you take care of all these things, your FMR has some standard inside the oral cavity as a restoration. And the prognosis of the restoration would be very nice. Kindly give a protective splint post the restoration as well. Because we don't know how the parafunction activity is inside the oral cavity. We must have not assessed it. So I need to protect my restoration. So what you can do after giving a restoration inside the oral cavity, you can just give one maxillary or mandibular splint, whatever, accordingly, 1 millimeter hard splint as a protective splint inside the patient's mouth. So that it does not damage the restoration. It might damage the splint. That's okay. The splint might break down, no problem. The patient will come back with a damage on the splint now. Then you can assess that, the patient is having parafunction. It acts as a diagnostic tool also for you. And you can probably do necessary changes again. So always give a protective splint. It doesn't only protect, it also diagnoses the case. Maintenance, I would prefer a flosser, water flosser always, and a 6 months maintenance protocol with the patient, both radiographically and clinically. Always check occlusion in supine and alert feeding positions. When you have to ask the patient to go into a supine position, or you take the patient to supine position, check with the articulating papers. You get the patient again to alert feeding position, which is a sitting position. Check the occlusion with articulating papers. If there is any discrepancy, you just strike it off. Create a freedom now, both in supine and alert feeding position, so that you don't have a hit again. Because patient sleeps, patient sits. In both the positions, the occlusion has to be stabilized. That's known as freedom in centric and freedom from centric. A long centric is what you create when the patient is sleeping and sitting. So this is how you need to stage it up. This is how you need to probably take the FMR in a sequence. I've made it very brief, but I made sure that I conveyed a lot of takeaways to you, a lot of points to you. People who are already doing FMRs, take away the points which you are not probably doing it in a sequence, and enhance the practice. People are starters or beginners. Take it as a session to probably introduce to the world of full mouth rehabilitations. Thanks to DMA, and we are coming up with this workshop with DMA very soon. FMR Marvel, it's a 3-module workshop which we are doing. You can contact Dr. Twinkle Jain. She has created this webinar group for that only, so that she can consider participants for the workshop with some offers as well. That you can talk to Dr. Twinkle Jain regarding the workshop. My job is to convey the science to you, all of you. So you're welcome to attend this workshop in Mumbai whenever it is possible. And you can always contact me, irrespective of doing workshops, irrespective of what you are. You can always contact me on these IDs and ask me doubts if you have. I'll be always open to answer back as well. So best wishes to all of you. I hope this was informative enough within the span that we have for the webinar. And see you all sometime very soon. I'll take up the questions now if you have anything. Can we use T-scan to assess the load and parafunctional? Definitely, T-scan acts as an accessory mechanism to see the loads. Definitely something which is good. You can use a combination of articulating papers and T-scan as well. I'm just coming one by one for the questions. Just bear me for some time. Can you please share the presentation? I missed the Dr. Nasma Ibrahim. Sorry, Dr. Nasma, I cannot share my presentations anywhere in public, but you can do one thing. You can ask your queries in the webinar group that you are in, and I'll answer all your questions. You can use T-scans 100% for assessing the loads. You can see the time, vectors, everything in T-scans. While taking a centric byte relation, should it be through and through? The deprogrammer should be flat or inclined or inwards. The deprogrammer should be always parallel to the occlusal plane. It should be flat. It should not be retroclined or inclined. The centric byte should not be through and through. It should be thick enough. You should not see any light passing through the centric byte, or it should not be perforated. That's why we use a deprogrammer to take a centric record. The protective splint is given usually during night times till my first recall, maybe 6 months, the patient. In between, if there is any problem, yes, I attend on to the splint. Zirconia is not preferred. We prefer zirconia for posteriors 100%. Only if there is parafunction, be careful, because it's a hard material. It might load the joint. Temporization 15 to 30 days, depending on the case. The moment you see broken temporaries after probably 15 days or something, you have to think in three-dimensional way. One is strength of restoration, strength of temporaries. Number two, centric relation. Number three, vertical dimension. You have to reassess all these things and get back to the basics again. Customized incisal table, you have to do protrusive and late protrusive movements. Just take the impressions of the temporaries that you have equilibrated inside the oral cavity, the final equilibration done, and then you take the impressions, forecast, put that on a semi-adjustable articulator, and then put some pattern resin on the anterior guide table and do the movements. That is customization. There is no safe number to increase VD. As I said, many cases will not have 1 to 2 millimeters increase as well. There is no safe number. I will not say that 5 millimeters, 6 millimeters is a safe number. 2 millimeter is considered to be okay at the max stretch, because we give splints and all in that VD. But when it comes to the FMR, it is very case specific. You have to sometimes maintain the VD at RCP. Sometimes you have to increase a little. It all depends on the bite and what we are seeing on an articulator. It's a good question. If bisacral temps in test drive are to be adjusted in relationship to the soft tissues, do you do it intraorally and take them out and polish? You can. It's a good question. You can do it intraorally, take out the protemp, polish it well, and then you can lute also. Many times you do that as well. If the individual is healthy means the TMJ is healthy, and if everything is favorable for us, how long does this procedure? You can keep 2 months as the minimum time period for FMR. Sometimes it takes 3 months as well. It all depends on a case. All right, I think we're done with the questions. If you have any questions also, you can put it in the webinar group. You're all there in the group, so you're welcome to ask me anytime. Go back to your practices and have a safe and happy evening, all of you. All the best.